Yes, we're ready. Clear your throat, everyone.
Okay. Joe, are you starting recording?
Yeah, I'll start the recording now.
Good morning, everybody, and welcome to the West Suffolk Clinical Commissioning Group September Board. Joe, do we have any apologies?
Apologies have been received from David Taylor, Jeff Rono, Victoria Wilson and Steve Chicken.
Thank you. Are there any declarations of interest?
Not from me.
Okay, thank you. Don't think the GPs are particularly conflicted in any way. Thank you. Anybody had any gifts? Shouldn't think so. No.
Christopher, I've got my residual declaration of interest about sitting as part of the hospital exec team as well.
Thank you.
It's not a new one.
No, thank you for reminding us. The minutes of the last meeting. Is everybody happy that the minutes represent a correct record of the meeting?
Yes, I'm comfortable with them.
Yeah.
Thank you.
Thank you.
Thank you. We will adopt those then as the record of the meeting. Matters arising. Any matters arising?
No.
The action log.
Okay, so we've
want to lead?
Yep, happy to. So we've got two. The first one is quite old now, but it relates to the A&E 4-hour target, and we are still in a holding position in terms of not having a confirmed date for the end of the pilot, unless Richard corrects me. No, shaking his head.
Could I suggest we take that off and we can pick that up once we do know when that is finished, because otherwise we just keep saying we've got no update at the meeting.
Okay, I mean, it has actually been going on for rather a long time, that pilot, and so therefore we've got a blind spot. Is that satisfactory, just to take that away?
Well, it's the specific. I don't think the governing body need to maybe hold the action. I think we can bring that into the executive if needed. I think this, if it's the specific around when does the pilot end, we're very much bound by the national timeline, of which at this stage, with everything else going on at a national level, there is no end in sight to that.
Okay, fine. Thank
you.
you.
I don't mind. It's just we'll let the executive know. We won't wait for the governing body every 2 months. We'll let you go through the exec once we've got an answer.
Okay, I think we had that conversation a couple of months ago as well. So
we'll
perhaps,
take it off.
Now is the time.
Thank you. Thank you.
Okay, and the second one relates to Sizewell C, and the query was around the safeguarding boards. And Lisa, I don't know if you want to come in, but there was an offer in August to present to the Suffolk Safeguarding Board to address this.
Yeah, and Jane Taylor with the Safeguarding Leads did a presentation to the Safeguarding Board a couple of weeks ago, which was very well received. Thank you.
Thank you. So we take that off as well. Okay, so as we start the meeting, we have a clear action log. Thank you. Ed, a general update, please.
Thank you. Morning, everyone. Lovely to see your faces, at least. So in terms of West Suffolk specific updates, I think there's a really excellent paper on the Alliance on the agenda, which I think covers some fantastic work. But I just wanted to particularly draw people's attention to the What Are We Missing event that's being organised for the 29th of September, which is a really, really important event with our communities. Because as we know, people from BAME backgrounds have been disproportionately impacted by COVID, and it's really important that we support and protect them and work in co-production with our communities to ensure that we're better prepared as we head into the next phase of the pandemic. And I'm sure we're all quite aware that the situation is changing. Again, the infection rate's increasing, and we're moving from a kind of recovery phase into a response phase again, I would argue. So the community event I described is really, really very important indeed. I encourage people to attend it. In terms of recovery, let's pay tribute to everyone involved with the recovery plan that we've submitted this week as an ICS. It's largely a green rated plan, but there are significant risks in it, particularly around elective recovery and cancer. But I'm sure we will be talking about that either in the agenda or at a future governing body meeting. Allied to the plan, we're working through Paul on a winter plan and through Lisa and others around flu and COVID vaccination and gearing up for that. So again, we may touch upon that later. And finally, in terms of planning, we've submitted a people plan, which is around our kind of workforce development, which we will discuss at a future meeting. I know we had a discussion at the previous governing body, but a couple of things to highlight from that is one, the Integrated Care Academy that we're developing at the University of Suffolk, and there have been some invitations that have gone out for people that are interested to help shape that academy. Do let me know if you want to either be part of an interview or enter a questionnaire. And then secondly, we launched a Health and Care Academy in Colchester recently, which was around attracting 16 to 18-year-olds into health and care roles. And we had a huge response and a lot of enthusiasm from those young people involved. That academy is going to be rolled into East and West Suffolk in coming months. So I'm very keen that we're sighted on that as it arrives in West Suffolk. Because I think we've got a great opportunity with the enthusiasm for the NHS and social care at the moment to attract young people into those professions. Final couple of things is Jane will no doubt talk about finance, but for the rest of the year we've been given a system allocation based on our spend in the first half of the year, and that's quite a different way of working, but I think it's the way of working will be in for the future, which is around a system deciding how the money is carved up amongst its partners. So it's very much a system first approach to managing our resources. And then finally, I just wanted to let people know that I'm currently sitting on a national committee looking at the future of public health. So people will be aware that there's been a new arrangement, a new body set up for health protection following decisions made around Public Health England. But the piece of work I'm involved with is around health improvement and how that's going to be organised in the future. So hopefully at a future governing body, I'll be able to talk about that work and get your input and your advice on how we shape it going forward. So I'd be very keen to do that. Thank you, Chair. That's my update.
Thank you very much. Does anybody have any questions for Ed? Okay, there being no questions, we'll move on. Thank you. We do not have a patient story this month. We hope to have one in a couple of months' time. So Kate, we'll move straight on to the West Suffolk Alliance update, please.
Brilliant, thank you very much. And Ed's already trailed the paper, and thank you for that. There is an awful lot in here, so I'm going to cherry pick some of the pieces and take questions. But it is a really important collection of examples and information about all the work that is going on by a small army of people who are all putting themselves in a space where they're being asked to work differently in a really difficult set of circumstances. So I think in some ways that makes the content of this even more powerful, especially when you look at some of the changes we've had to make in a very short turnaround time to change the way that we and our support offer to our population. So if I take you to section 2, it gives some examples that we've been doing to support the rehabilitation needs of people, and this being much broader than just health. So working in partnership with the hospital, with our allied health professionals, our IHPS, which provide our physiotherapy services, and Abercroft Leisure, who's our main leisure provider, looking for what additional support we can offer to people following their stay in hospital, or those who are still have had their procedures cancelled and are on waiting lists. And actually at the moment, that's an ongoing challenge on how we make sure we get those individuals seen. But the challenge also is how do we make sure we've got some wraparound support for them during the interim period as well. And that rehab support is not just about additional exercise, etc., etc. It's around creating a sense of community and having somebody at the end of a phone who can actually give some support to these individuals and let them understand what is available to them. And that also extends sort of more broadly with Abbeycroft Leisure, looking at frailty and falls prevention, and we've managed to roll out additional classes and GP exercise on referral in all of our localities now. And all of this is sort of accumulating a more visible role, I think, from a health and wellbeing point of view of the multidisciplinary team that we've got in our localities. Going down to the rapid intervention vehicle, which we spoke about in this forum several times, but that's there and going from strength to strength. And I think that helped us greatly during COVID in terms of already having a model about how you can intervene early and understand working together from an MDT, a multidisciplinary team point of view, to stop a patient deteriorating or having to present into hospital. And in the current situation, we've tried through all of our avenues to make sure we're keeping people safe at home as much as possible. Think 111 first is the catchphrase that's part of the policy around how we start to use 111 as a different navigation tool. Richard might want to add more to this at the end, but that work is progressing well, and I think it's something that's being committed to nationally, and we're in a good position to maximise the opportunity here. I'm not going to re-rehearse the "what are you missing" conversation because Ed thankfully has trailed that already, but I'd just like to say how enlightening and enjoyable it's been to be leading and part of these conversations and working with the Ipswich and East team. I think the most striking thing is the different voices that we've already brought into that conversation. And also just reflecting on the messages that are coming out as part of those conversations, but also where we've got small communities or support groups set up already within some of our health organisations, how they view their role and getting them to be slightly more ambitious about it, not just being about the staff within their building, making sure there is sufficient PPE. It's about them seeing themselves as being leaders and a voice for their communities that they represent as well. And that's quite a journey to take people on, but I think I'm excited by the fact that we've got quite a few people who are willing to step up into that space, which is brilliant. We've got some details around the virtual ward and some case studies, which I won't go through, but I think that for us, when we're trying to bring staff into a collective space about working differently, the case studies are always the most powerful piece, and each one of these gives a good picture of why working together and trying to take down some of the boundaries between teams is still very clearly the way that we need to be empowering teams to work. And the virtual ward impact feedback and just some of the quotes there from patients, just to draw your attention to. I think you can see on a very human level what it means for someone to have very clear line of sight of who is helping them navigate through their journey, not being passed from one set of professionals to another. And I think that championing of the individual and listening has also brought a significant amount of reward to staff, and you can see that in the staff feedback, which I think has been incredibly powerful. And also we'd like to try and use some of that feedback to other bits of the system that aren't necessarily working in this way, just to help them to understand that actually this is part of what we need to be able to achieve and prioritise. And I think from a internal hospital point of view, some of that sometimes gets lost in translation because they're seeing their role on a ward when actually the person that comes into their care has a life outside and a life the other side of the ward as well. So we're using some of that information to also bring them on board with some of those conversations. It's quite a big section on telehealth and virtual clinics. And we have had a mini revolution during COVID on this in this part of the digital world. And I think in primary care, it's been incredibly dramatic, and we've covered it before. And that was very much led by our teams, but also by our GPs championing and realising that's what needed to happen almost overnight. And some fantastic work that's detailed here was part of that. The hospital have also mirrored that in terms of changing the way they have run their clinics, but I think you can see from the figures, and they this is part of their current conversation around recovery, there's more that they can go at in terms of the video conferencing. There's some very low figures there, and the telephone ones have sort of taken had more of impact and had a stronger uptake, and some of that is around the logistics of that, but that's something that's a work in progress. I've already trailed general practice, but I think given the news and where we are at the moment as a country, it's important just to note here, the good work that went on and the learning and the infrastructure we now have in place around care homes, around practices, around pharmacies, some of which has been stood down. So the hot hubs and looking at those emergency measures are no longer in place. But what we have now is the muscle memory and the plan and the ability to understand if and when needed how we can stand these additional support services for our population up and the support services for our staff up in a very short turnaround time. So I hopefully that is reassuring, and definitely in a completely different place to where we were, as Ed referred to at the beginning of the current crisis that we find ourselves in. And then, sorry, just to whiz down the only other points, we're doing a significant amount of work with our alliance governance structure, looking at mirroring some of the moves that have been made within the other two alliances, looking at how you empower the alliance to be able to take on some of the challenges going forward, and becoming a delegated committee of the CCG board, which is very jargony, but basically would empower it to be able to take on more responsibility and bring that integrated agenda very much into its own in terms of making decisions, etc. And just to draw attention to, we have also appointed an independent chair, which I think I may have referenced at our last meeting, but she is now in post, Sarah Howard. She started at the beginning of September, and we're delighted to have her on board. Okay, I'm going to leave it there. I would commend you to some of the lovely feedback from the virtual ward, which is appended to the paper, but happy to take any questions.
Linda, I think you were first.
Thank you, and thank you for the excellent paper. I think it gives a really good understanding of people working together and the direction of travel within the West Suffolk Alliance, and it's really encouraging to see the patient stories and individual examples, which, as you say, are very powerful. I would just add one to the first case study, which the very last line says, you know, with thanks to everybody involved. The one person that I think also needs to be credited there is the wife or the carer, because often it is with, you know, without the carer being at home, a lot of this wouldn't be possible, because you need that 24/7 support. And therefore the carers need that support as well as part of the total package, which I think is inherent in that story. But perhaps if we draw that out, it just makes clear the importance of the carer and somebody else being in the household where that is possible. And the one thing that came out from some of the comments in the appendix was the importance for the family or the individual to know when that visit might happen from people in the community. And people like British Gas and others now give you a sort of slot time. I know some are quite long slot times, but I wonder if, as we're developing such excellent connectivity, we might just also add into the equation perhaps giving an hour's slot when it might be possible for these visits to happen. I do completely understand that if, you know, a nurse or a therapist or somebody needs to stay longer, they need to stay longer. We appreciate that. But there are automated systems that might help. As we've got such wonderful technology at the moment, it might be something else just to add in the mix. But thank you for such an enlightening paper. It's really helpful.
Thank you, Linda. Both those are really useful. And I do think just on the carers point, we've got a lot of very, very tired carers. And we were talking about this last week. If potentially we have another period where people are going to have to isolate again, I think that is very daunting. So what the support that we have in place, that's part of the conversation with the hospice, but we need to have it more broadly. Thank you for that.
Thank you.
Thank you. I think Richard might have been next, if that's all right. Just
quickly, because Kate mentioned think 111 first, so I'll just cover it briefly now rather than later. So we've got a business case in development across Suffolk and North East Essex for the national development, effectively, which is talking about a range of initiatives to improve the usage of 111 and reduce the walk-in activity going to A&E. So there's a national expectation with the pilots that are in place already. I think there's 3 in England, that around 20% of walk-in activity will be reduced by basically a big communications exercise to get even more people to use 111 and increasing the staffing, both clinical and otherwise, in 111 to manage that activity. We're bringing the business case, Christopher, through to the executive in October, so we'll be able to go through that in more detail. But just to say up front, this is a national initiative, so it's one that we're being asked to start to ready ourselves for implementation from early December. But as I say, we'll be able to get into more of the detail at the executive in, I think, 2 or 3 weeks.
Thank you. Ed, sorry to make you wait.
That's no problem at all. So, I mean, it's probably an unfair question. I know there might not be an answer to this, but it's around that Abbeycroft Leisure. So, I mean, I think the work we're doing with them is really groundbreaking. I haven't seen that in the other 2 alliances or elsewhere in the east of England. But as Kate and I know, there are challenges around the sustainability of leisure centres because of what's happened during COVID. People aren't going to leisure centres. So I'm just interested, Kate, in your thoughts about how we can build on that collaboration that we've got to kind of change their business for the future.
Thank you. It isn't a neat answer, and it's done absolutely in partnership with our district and borough colleagues who are the lead commissioner for Abbeycroft Leisure. But I think together, and you've played a supporting role in this, so thank you very much. We very publicly championed the fact that if we lost Abbeycroft Leisure as a stakeholder in our communities, it's not something that can be replaced. It's not a shop shutting and a new shop opening. This is something much more fundamental in terms of being a really active part of the DNA of what we're trying to achieve around integration. So what we've been doing with them is working up what their input into a locality model and a support kind of network across the core pieces of our communities, as well as our health and care professionals, could look like. And actually they're looking at their business model through that lens to see, actually, is it something that we could use to enhance our work around social prescribing, health coaching, just more health and wellbeing active lives programme going forward. So that is a work in progress, and that runs in parallel to the conversations that we're having with the national team around support for the leisure services as well. We've also started to explore just conversations about how we could partner with Abbeycroft in a different way with some of our other providers, looking at if that gave their business model more stability in the long term. So we're doing everything we can to work with them and through helping to stabilise the ship, but also maximise the opportunity, which they're very open to. And when we look at the role they played during the peak of the most recent peak of our COVID experience, they rolled their sleeves up and were willing to do anything in terms of manning, opening up their estate to provide equipment, storage, manning receptions, going into localities and volunteering. They were absolutely part of the team. So in some ways we've already trailed and piloted this way of working. It's now trying to formalise what that model might look like.
Thank you, Kate.
Any further questions? Further discussion? Okay, well, thank you very much, Kate. That's very comprehensive and gives a great feeling of progress. The Community Engagement Group and Patient to Public Involvement. Linda, I think this one's for you.
Thank you, Christopher. I'll take the paper as read, but are very committed and willing volunteers in the community that belong to our Community Engagement Group have been meeting monthly virtually and have been sharing their experiences, and we've had a number of speakers as well that and in fact Joe Cowley came last time to share some of the experiences that were happening in the West Alliance. I have to say the examples in the paper, I think we would like to share that paper tomorrow when we have our next meeting, because it gives a lot more of the detail and patient story, person-specific information, which is, I think, what the group were looking for. We have had some questions raised, and you can see the issues in the paper, or some of the issues that we've been talking about, to see how the group can help in the winter plan, help with getting messages out to the public, and as well as their role to bring information to the CCG from their connections. We have had various participation in interviews and various groups and transformation and delivery opportunities to make sure that the patient story patient voice is also heard. I think our particular issues that we are concerned about at the last meeting were around the flu vaccinations and the pneumococcal vaccinations, and how we might support surgeries in delivering the vaccinations and getting the message out to the public to attend as appropriate. The other area that I think is coming to the fore in the stories that are being told is around not only the integration, which we're delighted to see in various health and voluntary organisations improving, so the patient doesn't have such a fragmented experience. That really does seem to be making a difference. I think the next step then is between health and social care settings, and getting the communication and the handovers of care clearer, so that the patient does get the continuity of care and the continuity of advice and help that they require. So I think it's that junction that perhaps is the next one to focus on. But we can see lots of positives happening through this experience of COVID and the different ways of working. The virtual appointments have gone down a storm, I think, with the public, and it has helped certainly our members participate in other groups, because they were having to travel otherwise quite a lot to Ipswich and Colchester. Now it's done virtually. They're able to participate as well in those patient stories to the different groups that we've been invited to join. So I just offer the paper and the examples of questions and things that we have presented to the CCG, and just recommend that that you note and consider those issues, and if there's any questions, we're happy to take them, and I'll take them back to the group tomorrow. Thank you.
Thank you, Linda. Does anybody have any questions for Linda? Kate?
It's a comment, really, as always. All brilliant stuff from Linda, and I think we need to work out how we link the what matters to you, what have we missed conversations, into our CEG, our engagement work, because I think there's going to be some richness there, and also some more diversity in terms of age range, as well as ethnicity, which is what you've been sort of striving for a while as well. So we need to make that link.
Thank you.
Thank you. Jeff?
Thank you. I was just looking at one of the issues about localities and Newmarket that Lynn Byrne has made. I think I would agree with that. I'm not aware of any locality meeting in Newmarket, so I would support her observations on that. Thank you.
Thank you. We have heard that there are working groups happening in Newmarket, and I think there's quite a lot of things happening, but not as, or at least we haven't had the invitation to attend a locality meeting, whereas in other localities, it's been much easier to participate virtually in the meetings and to be able to contribute. So we have taken that back to the leader of that group, and hopefully there'll be something forthcoming soon. Kate, I don't know if there's anything else you can add.
I was just going to come in because they definitely are meeting, as they're the ones that are trialling quite a lot of the Abbeycroft work and the sort of broader volunteering piece. So it is disappointing to hear that when I read that. And Sandy is our lead for that locality. So that should be an open door. So absolutely, I'm happy to support taking it back. The larger locality gatherings, obviously during COVID, were stopped, and there was not stopped, but met less frequently, and there was more of a focus on that integrated neighbourhood team, almost the operational piece around actually what needs to happen by when. But again, that's not an excuse. We need to make sure that there is still that broader conversation, and we need to also make sure that we've got the public and our lay members' voices in it as well. And Jeff, you've been mentioning this for such a long time. I'll take it away and email Sandy again. Thank you.
There are some good examples as well. You know, Bury Rural have been meeting virtually, and I've had no problem attending those meetings. So there's some good examples too.
Thank you. Paul.
Yes, thank you, Linda. I'm stuck by your point around winter plan and the role and support that's required, and I'm really quite keen that we don't lose that point. Now, the way we are choosing to pull the winter plan together is by working through the alliances. So I just want to make sure that that discussion is taking place and can feed through the alliances and find its way into the winter plan. So it's just a plea to make sure we don't lose that comment and that input.
Thank you.
Yeah, and that's doable. And I think it might be that Katie needs to become part of those conversations, or whoever the equivalent is if it's not Katie.
Sure.
Thank you.
Okay, any further? Thank you very much. Thank you, Linda. Paul, procurement.
Oh, thank you, Chair. Okay, this is a fairly routine paper as I understand it, and I will take it as read, but I'd like to make a few observations, if I may. So obviously procurement has been affected in pretty much the same way as every other services because of COVID. So a lot of our procurement got either stopped or delayed because of the impact on transformational programs, etc. So this paper really represents the current procurement that are in trend. But the bit that interests me the most in this report is probably the final 2 paragraphs in the report, which talk about our need to review our policy on procurement. Now, clearly, there are lots of uncertainties at the moment, Brexit being one of those, but equally nationally, there is a trend to move away and move toward a lighter touch, competition and procurement rules. But actually, the legislation hasn't yet caught up. And as we get more and more innovative, we have a juxtaposition really between what we would like to do and what the legalities tell us we can do without having a challenge. So it is absolutely right now that we take another look at the policy, even if Brexit hasn't been resolved. If Brexit happens and changes things, then clearly we need to review that. So it's just a signal this is quite, I think, a fairly important piece of work, given everything that we're trying to achieve. But more fundamentally, really, we'll be bringing forward a proposal to essentially stand up a procurement panel, which actually will support all 3 CCGs to help make those decisions, join up the strategic intent, if you want, the decision we have to make around procurement, and keep us safe as an organisation to make sure we take the right routes, because some of the consequences of getting some of these things wrong can be quite significant. So happy to answer any question about the paper, but I think it's pretty routine paper and self-explanatory.
Thank you. Does anybody have any questions for Paul? And Andy?
Yeah, it was just about pathology services, Paul. I just saw there was like this frightening deadline in the spring of October that the Ipswich had given notice to West Suffolk to find another provider, and I see that that's been extended. And so what is the working relationship carrying on as before? Because it was a little bit there was 1 or 2 issues with it. Mm-hmm. And is it now carrying on fine? And how's that progressing?
Okay, so this is quite a complex issue. So as I understand it right now, essentially there has been addition back to 2 organisations that the current arrangement will no longer stand. They're working through a transitional plan at the moment to essentially separate. However, they have totally accepted that until they've actually joined the relevant networks, which makes sure that sustainability can happen, there will be an ongoing working arrangement to subcontracting. And that position will remain until the network issue is resolved. So that work is ongoing as we stand at the moment. The bit in the paper around the procurement is about the primary care element of the procurement. And as you're aware, partly because of COVID, but partly because when we went out to procurement for the primary care element, we were significantly challenged by a third party, that we've had to take a step back and really think about what is our correct approach. And the real importance of this is that we really want to work as a system really and make sure that our services are as integrated as they can. So getting that right is quite important. A proposal is finding its way to our joint leadership team on the 28th, which is going to set out what that approach ought to be in order, A, to keep us safe, and B, to get us to where we might want to land in terms of the service we might want to see in the future. So in part, some of the work is quite advanced, but in part, we've had to take a step back and really look at what our approach would be to the procurement. A procurement is likely to take 12 to 18 months. And there, as you know, there are some national changes likely to come on board. So again, it's a bit of an uncertain time. I hope that sort of answers your question.
No, thank you.
Thank you. I mean, it does strike me both in pathology and mental health services that it would be quite useful to have a paper to exec in the not terribly distant future on each of those two, where we are and where we're going, so that people are reassured that we haven't come too much off track in either of those disciplines with where we are. Richard?
I'll cover mental health a bit later, Christopher, on the IPR, but just to give you that assurance that we are bringing something through to the executive in October, specifically around the next steps on the mental health transformation work, and specifically on crisis.
Thank you. Anything else on Paul's paper? Thank you very much. Oh, Jeff.
Hi. Answers to Paul, really. Thanks for the update. When are you expecting to bring the procurement terms of reference, etc., to exec and governing body?
So there is a decision to be made, I think, on the 28th with our joint leadership team. If the view is supported and we're bringing it forward into our approach, then the paper can fairly swiftly find its way forward.
Thank you.
Thank you. Right. So that's the end of that section. So now we're going on to finance. Oh, Andy, do you want to come back before we go?
I just wondered who's inputting on the primary care section of the pathology, Paul? Who's working on that?
So I think there's been a long established piece of work that's already been done that has been fully engaged, is my understanding. What I will do after your question is make sure that the right people are re-involved to re-review what we've already done. So I'll take that away.
Thank you.
Thank you. So we now go on to finance, performance and scrutiny. Richard, would you like to lead us, please?
I think Paul is taking a lead now in his new role.
Okay, thank you.
Thank you, Paul.
Thank you very much. Okay, so again, quite a large report. I will take it as read. But if I can just give a bit of an overview, what I think in part the report is telling us from a KPR, sort of a hard target sort of point of view. I think the report needs to be seen still in the context of COVID. Clearly, COVID has had a significant impact on some of our performances. The other thing I sort of like to say is the shadow winter pressures and shadow a second wave may also very much play a part as we move forward in terms of performance. The third bit really is clearly the IPR report went to clinical scrutiny committee, and I'm sure members of that committee may have something to say around some of their observations. And if you note the minutes of the meeting, there was quite a lot of work on cancer and various other questions and scrutinized element of the performance, which has sort of already happened. But I'd like to make a few comments. So if you theme the findings, cancer actually, where it is not where we'd like it to be, in my opinion, is not doing too badly. We are seeing recovery in elements, even though referrals are going up. So again, if you look at West Suffolk and if you look at Cambridge Acute Trust, the figures appear to be moving, either being fairly stable or moving in the right direction. What invariably we will see, though, around cancer is whilst we look at and manage the backlog of 104 days, you are likely to see 62-day performance drop because people are being treated much quicker, and that's how the figures pan out. In terms of focus, I'm sure Richard will talk about this, but it's been very much about increasing capacity, standing the services back up. We are seeing a lot of the diagnostics really coming up back to par. MRI scan for trusts like SNF is back to 6 weeks. West Suffolk FT are working on same line for MRI and CT scans. The biggest risk and the biggest issue is endoscopy because of the impact of COVID and the need for social distancing and all the things is proving a challenge. But again, we are working with private sector. We are working with as much of additional capacity we can and thinking about alternative approach to diagnostics. In terms of the work that Richard is doing as part of the Transformational Cancer Board, there is really a high focus now on focusing on rapid diagnostics. And I know that Richard and the team there are very keen to push that because that's partly where the biggest risk is likely to be. In terms of good news, I had an email conversation with Helen Beck, the coup of West Suffolk FT, I think on the 16th, where she detailed that the long wait is 104 days had gone from, I think, 76 down to 21 now, which is, again, a good news story, and they are focusing on that. So whereas I think there is absolutely the right concern around cancer, I think cancer is doing relatively well given where we've been, but we've got more work to do. The focus for me, though, is when you start looking at RTT, you'll see the way the referrals going up. You see 18 weeks sort of going further out to kilter. Our waiting lists are increasing, and our 52 weeks equally are on the increase. This needs to be really seen in the background of the recovery piece through the Simon Stevens letter phase 3, which asks us to increase our capacity by December to 90% of all elective capacity, 100% of diagnostics, and all the trust certainly have put into place some action plans to demonstrate that they can actually achieve that. The problem being is that you already got a backlog, and essentially unless you get to 120, 130% capacity, then that issue is likely to carry on getting worse in my opinion. This leads us to another vital piece of discussion, piece of work, which is around how do we risk stratify and protect patients from harm that are on those waiting list. And that is a discussion that is really live at the moment and going through the SNE Recovery and Restoration Board. There is a regional committee, I believe, that's been set up to look at that issues, and I think there are some guidelines about to appear very shortly. Nick Jenkins from West Suffolk FT is preparing a paper again to talk to us about how we might achieve risk stratification of patients, make sure we don't magnify the inequality in health, etc. And that discussion is going to happen very shortly. So I would just like to flag that there is clearly an issue around that performance, but we are going to have to start thinking differently as to how we manage that group of patients. On the mental health, interesting. If you look at NSFT performance, at the 11 or so KPIs, I hope I can count. I think there is about 3 that remain static, but actually the remaining 8 have slightly improved. So again, they are not where they should be necessarily. I think they are going in the right directions. The quality performance contracting meeting I've restarted on a monthly basis with enthusiasm. I've attended that first of the restart meeting, and it was a really positive meeting with the right discussions taking place. I personally have been invited to be member of the Finance Performance Committee at SNF, and now attending my first meeting. Again, really good news in terms of partnership workings, and I've also engaged Norfolk into having some discussion about developing outcomes-based, sort of KPIs, and I'm sure that'd probably be music to Lisa's ears in terms of certain aspect of the service. So again, some really good engagements, some further work to be done. The other bit on mental health that I would point to is the impact on physical health checks and dementia. I think we need to note that, and I know that the teams are working hard to try and address some of those issues, but we shouldn't ignore those elements of the performance. And finally, the remaining bits for me probably surround the patient transport and ambulance services. And whereas performance has been reasonable and actually each of the providers have been supportive in terms of achieving the KPIs. Winter is looming. We're still not there in terms of the actual arrival for the PTS, the services, to their appointments. So again, that's ongoing work. Need to keep a watching brief as pressures increase. And from an ambulance EE's point of view, we need to be slightly mindful that the category 2 responding is slightly creeping up. And again, the teams need to start focusing on make sure that we are on top of that in terms of our way forward. So I'm going to stop there. I think, and I suspect that some of my colleagues from a quality transformational point of view would probably want to tease out some of the aspects of their work that they're doing that supports performance improvement, and happy to try and answer any question.
Ed, you're first.
Thank you. I mean, maybe Richard might want to address this question, but if we head back into high COVID demand again, what's the work we need to do to get prepared for that surge in activity, and are those plans ready on the shelf to mobilise, or is this a new piece of work we need to do?
So Paul might want to come in as well on that, because it kind of straddles winter planning and recovery planning, but in essence I think we're part of the way there. So both Paul and I and Kate with the West have had a meeting with the trust management, so Helen and Alex, to go through their month by month basically bed plan and activity plan to understand what assumptions they've made month by month in terms of the impact on capacity. So you'll recall, Ed, that the national team were clear that we should assume, from a bed capacity perspective, an 8% contingency, which is the standard, so effectively set your plan at 92%. As it happens, West Suffolk FT and ESNEF have also put in more contingency, because I think now on reflection, I would agree with them that they felt that would not be sufficient if we were to get a second wave. So they've gone over that in terms of the number of bed capacity effectively that they have put to one side as a contingency for any further spikes. What we've asked them to do, and again, Paul might want to come in, is to basically need to go through that again in more detail, really, to take account of any further data that's likely to come out from the national team in the next 24, 48 hours that I was alerted to yesterday. And then, as you know, we're looking to have a meeting towards the end of the week to really understand how robust is it before we have any regional meeting the following week. So I think, like first wave, it's going to be a live document, and we'll need to plan as best we can, but we'll need to see what the weekly actuals are looking like to see whether it's on plan or whether we need to make even more contingencies. I think the work Kate described in the community is essential, because West Suffolk, yes, is looking at what contingencies it can build in from a bed capacity point of view, but for many of the issues we've talked before about the constraints on that site, we need to look at other ability, like our community hospitals and our community facilities, to help bolster the acute response.
Thank you. Now I can see 3 hands. Are any of them on the topic of recurrence of COVID preparation, therefore?
Mine is, Paul's is, okay. I think.
Godfrey, are you happy for me to take those before I come to you, which I guess is a different topic?
Yes, I'll be happy with that.
Thank you. Okay, so first was Kate.
So it's just the marker in the sand, because I think when we talk about winter planning, we do very often talk about the acutes and what's required, and we just need to keep a very firm focus equally on support and readiness for primary care. So we are having those conversations, and I think we won't have some of the trials and tribulations we perhaps had first time round, but we are also still at the back of the queue for some things that we need to make sure as a team we're supporting practices with. And at the top of the list would be around testing at the moment for staff, and how we mitigate some of the things that we can already see are going to become pinch points. That very much is the conversation that the teams are having, and then that's also, which is also a positive, is being escalated up through the structure that now exists sort of at a ICS and a county level.
Thank you. Paul?
Yeah, I just wanted really to concur with Richard a little bit, in the sense that I think our approach has to be about putting reasonable assumption within our bed base through the winter. But I think there is always the possibility that we do end up with a really rising tide issue around COVID. And I think that for me is plan B. So actually, how would we respond now? We've already got a lot of the learning from the first wave that we can pick up and build into a plan B. But the issue for me is I think we're still waiting for some guidance from the centre. Clearly, I think they're waking up to that issue and are asking the right questions. We just need to agree how we do it, whether we do it as a single plan, in which case it would be really, really quite daunting and maybe unachievable, or whether we actually have a plan that says this is a reasonable assumption, but actually this is how we would respond in the event of a really rising tide issue around COVID, which may be a slightly different response. But I would agree with all the points that have been made.
Thank you. Linda, are you on COVID recurrence, or are you on a separate? You are. Okay, Godfrey, if you don't mind, we'll hear from Linda next.
Thank you, Godfrey. Thank you, Christopher. It was just a comment around the importance, therefore, if a second wave is on its way, is to increase the amount of virtual and video and telephone outpatient appointments that the hospital has. As you pointed out, Kate, in the West Suffolk Alliance, some of those specialities are extremely low and still maintain most of their appointments by face-to-face, that surely if a second wave is coming, then accelerated telephone and video outpatients would therefore keep the other services going as well during a second outbreak.
I think Richard might have something to say on that.
So 40%, to be fair to West Suffolk, currently 40% of their outpatient appointments are virtual, which is one of the highest in the region. There's always more they can go out, but they're doing well on that, but they need to keep up that. But I think, as you and Kate and yourself have both said, though, there's a very differential approach between the services, so specialties. So there's more we can do on that. And I was going to update later when we come on to the transformation programmes, but as I've got the floor, I'll do it now. So Sandy and Alex Baldwin have agreed to co-lead that piece of work around our outpatients work ongoing. And there is a clinical reference group, I'll get the title wrong, Kate, which the trust are going to be leading. We're going to be bringing some of our GP leads into that, which will effectively be the rebooted West outpatients elective transformation group. And one of their key focuses is around all the regional, what's called adapt and adopt outpatient areas that they want us to look at, and it's detailed in the highlight report in the IPR. So like virtual outpatients, like good newsletters. So ESNEF have done this for a number of years, where effectively rather than bringing someone in, if it's just test results which are positive, they'll either send the letter out with a phone number or they'll phone them direct, and there's a load of other things. So I think with that rebooted programme, we're going to try and do even more to try and divert face-to-face activity. But at the same time, we know for some elements of our population, face-to-face is absolutely important. And also you can't do everything virtual. So we've got to make sure we keep both avenues open to our local residents.
Thank you. Godfrey, your turn has come at last.
Thank you, Chris. I think Richard's and Kate's comments have helped a lot in one or two of the points I wanted to raise, but I wanted to go back to Simon Stevens' letter, Phase 3 Recovery, which was quite a proscriptive letter in terms of targets, and my reading of it is that there was linked to those targets the potential for essentially financial penalties for hospitals that didn't achieve the targets that he was proposing. We've now got a situation where instead of recovery, we're heading back into a phase where COVID may be increasing, and there would seem to be some tension between the prescriptive nature of that letter and the situation in which we actually find ourselves. So my question is there an expectation that something may come from the centre decoupling the potential for financial penalties for the hospital if it doesn't meet the targets in the recovery letter?
Ooh.
Yeah.
Richard.
I'll start, and maybe Jane will want to give a reflection. So you're referring, just for other people's benefit, you're referring to there's something specifically in the guidance that came out which talks about each acute trust needs to meet the trajectory. So as Paul described earlier, effectively working towards between 90 and 100%. It's actually by the end of October, not December. So we've got to do it quite rapidly, and the trusts have committed to that. But on the actuals, absolutely, it's a challenge, and it'll be an even bigger challenge if we don't hit, you know, if we get a second spike. And linked to that, there was a financial regime that I'm sure Jane will describe. My own sense is that if the NHS does experience a second wave, I would imagine there will be a reconsideration of some of the guidance that has come out, but that's just my personal view. To date, there's been nothing come out, but to be fair, we've only just had the Prime Minister's announcement yesterday, and things are changing on a daily, weekly basis. So I think there will be some review of it, but that's just my personal perspective.
Mm-hmm. Okay, thank you.
Thank you. Paul, anything else then on the integrated performance report, or are we going to somebody else now?
Unless any of my colleagues want to actually pick up any of the quality and the transformational issues they want to pick up.
Yeah, I think we're going to Ms. Nobes next.
Okay, right. Thank you. Lisa.
Thank you. So I just wanted to kind of give you an overview on a couple of things that aren't included in the IPR that have been, one of them been referenced in the earlier discussions before we move on to the providers. But Ed talked about flu preparations, and just to give you the context, so we have a Suffolk and North East Essex flu and COVID vaccination board, which reports into the regional board, which has a number of work streams that pulls together all the work that primary care and the acute trusts and the mental health trusts are doing to increase the number of flu vaccinations, both to staff and to patients. And our providers have been asked to do opportunistic vaccinations of people fitting criteria, both acute trusts and mental health trusts this year. And also sitting in that governance structure is our preparation for mass COVID vaccination deployment, which is obviously the regional team are leading on, but we are very keen to be involved and ensure that any mobile units for vaccination and any work that's done fits the needs of West Suffolk, and isn't just come from a regional flavour. So massive piece of work, and that kind of filters through all the work that we're doing with the providers at the moment, but isn't specifically picked up around performance on the IPR. The two other pieces of work that I just wanted to refer to is obviously we are leading on the CHC continuing healthcare restart. So we are now working our way through all the deferred assessments. You will remember that there was a pause in assessments for CHC, and we have now started to work through the deferred assessments, as well as ensuring that we have timely response to ongoing assessments. So that's a key piece of work to make sure that people have the funding that they're entitled to for continuing healthcare. And the other piece I just wanted to refer to is that Suffolk has been asked and has actually nominated themselves to be one of the first systems to have a send visit by Ofsted and CQC as part of, it's not part of the overall monitoring against the code, the reform code with send, but we're having a visit from CQC and Ofsted in October to look at how, as a system, we have supported children and young people with send through COVID. So they're going to be with us for 2 days. They're looking at case studies and will be interviewing families and children and young people and practitioners that work with those children and young people. So we have a lot of really good things that we're going to be able to share with them, but it will be great to get their feedback as well on things that they think they can improve. Obviously, they're looking at it nationally, and it won't be published because it's not a formal part of the monitoring visit arrangements, but I'm sure in Suffolk we will want to make the outcome of that visit public. So that's something I can update you on as we move through. So I'll pull out highlights. There's a lot of information in the IPR pack on the providers, but Specifically with West Suffolk, we continue to have oversight through their improvement board on their improvement plan, which focuses on a number of areas that the CQC raised. Obviously, a key focus of that is their maternity services. And we have a programme of inspections and visits to test the actions that they feel are now embedded in their maternity services. And we kick off with a well-led inspection, which has regional team involvement. We have the regional chief midwife and a consultant obstetrician from another tertiary centre visiting, 6 people visiting this Friday to do clinical walkarounds and to have discussions with clinical leaders from maternity to test whether we feel that they've moved forward and implemented the improvements in maternity. We are also going to be doing some quality assurance visits to test their medicine management process improvements. You will remember that the CQC identified a number of issues and concerns around their storage of medications and some of their management of medication process. So we are planning on testing those improvements within the next 3 weeks, involving our meds management teams and pharmacy colleagues. And the other area that we are working with West Suffolk on that has stemmed from some serious incidents and just some intelligence, both from our county council colleagues and from the safeguarding system, around care pathways for people with learning disabilities. So we're doing a multidisciplinary review of the treatment of people with learning disabilities, tracking their pathways from presentation into ED and through the elective pathways, and looking at whether reasonable adjustment processes were made and best interest decision making was made. So that's some of the key things that we're doing with West Suffolk. I'll just go on to mental health services. So there's a lot of information in the pack around oversight of access and assessment team and the early intervention psychosis service, and the increased demand from patients who have first episode of psychosis. The other 2 areas that we are really working with them on is the LD and the CYP. So learning disabilities has been a great success story for NSFT. We only have 1 inpatient in their learning disability ward, which you'll know is in Walker Close. We haven't had a single admission to those services since December, and that has really been a great piece of system working with Suffolk County Council to make sure that the right services are in the community and responsive, so that we can avoid admission. And that's enabled NSFT, which you may have seen, there's been some media recently, to refurbish and to really improve the facilities at Walker Close. We've got around CYP, we have the new CYP leadership team in, who are really doing a root and branch review of all their services, they're reviewing all their cases, waiting for assessment. We've seen some great performance in the emotional wellbeing hub, 86% response to referrals within 10 days. We have seen decreased demand into that service, so that it is in the context of that, but we are enjoying working with the new leadership team who have a lot to bring to the Suffolk system. And the other area that I will just raise is with East. So you'll see from the IPR, we have continued oversight with the safeguarding allegations through fortnightly meetings, and we have seen improved management through their safeguarding team. We're now overseeing 16 cases, which you'll remember months ago we reported initially was 85 cases. Just to advise you that the CQC have undertaken an unannounced well-led inspection. We don't have the final report yet. It's with the Trust for Factual Accuracy, but we have had an early meeting with NHSEI and Health Education England, Health Watch, all the key stakeholders, to really make sure that there is agreement on what we all consider to be the key risks and the actions that we anticipate may come out of the CQC report to make sure that we have an early response to that. I'll probably leave it there, but I'm happy to take any questions. There's so much information in the pack that you may want to draw out individual things. Thank you. Chris.
Any questions for Lisa? Oh, thank you, Lisa. Right, next will be Jane, I should think. Yeah.
Okay, thank you. So included within the pack is the financial summary up to the end of August, so that's month 5. And as you'll, just as a reminder, we are working on in a very unusual financial situation, which has been centrally calculated and mandated to us by the national team as part of the emergency response. I will talk later on the agenda about the arrangements from October onwards, but until September, we are working on a system whereby each CCG is given an allocation, but is also able to reclaim top-up monies, particularly for COVID-related expenditure, but also to ensure that the CCG breaks even. So the financial report is quite difficult to understand without that context, because what's happening each month is that we're reporting the expenditure that we've made to date, but we're also showing of the top-ups we've received, how much they have brought us back to break even. So effectively, we've got 4 months worth of the top-up in and 5 months worth of expenditure. So the report shows the expenditure up till the end of August. In order to bring us back to break even at the end of August, we are making a claim for £2 million to top us back up to break even. That's pretty much all COVID related expenditure. There is a little bit of pressure in the general budget, particularly around continuing healthcare and other areas, which we did go through in detail at the Finance Committee, so I won't prolong that. But we're continuing to monitor expenditure in a number of areas, including on the primary care delegated, which has been an ongoing issue about the level of funding within the primary care delegated, which hasn't gone away with COVID. That's just continued as we would have expected. So there is a narrative in the report around the areas of variance. Most of those, to be honest, are related to the way the national calculations have been made relating to the allocation that we're given is split down into the main expenditure categories, and they don't automatically tie up with the payments that we are mandated to make to our local providers. So there are some variances in there, but we tend to look at the bottom line rather than the specific variances until such point as we are able to adjust the budgets, hopefully in the second half of the year. So I'll leave it there. I realise that it is quite a confusing report, but basically the main message is that we're continuing to monitor expenditure closely. Most of that is mandated for us via block contracts for our key providers, and we will continue to make claims up until the end of the emergency period at the end of September.
Thank you. Any questions for Jane? Okay, thank you. I think that probably concludes the integrated. No, it doesn't. Richard, who's next?
I don't know what's going on with the two chairs this week. I'm feeling well loved. Mark left me till the end as well, and we've got Kate as well, haven't we? Or I think we might be covered up. No, well, right. Okay. I'm only one. Don't worry. So we've got a couple of slides from the main transformation programme. So just draw your attention to the headlines, but I'll also just cover off briefly phase 3 recovery, which we've kind of dipped in and out of through the discussion so far. So the deadline for our submission was Monday, which we've met, and there was a suite of documents that we've submitted, which I'll make sure are circulated to the board today, tomorrow. So the first is the narrative plan, which I think, as Godfrey said earlier, your comment on the guidance was very prescriptive. So there is a set of asks from the national team on phase 3 recovery that we've then gone through and effectively set out how we're looking to put that into place, if not already. And a lot of it we've already got underway anyway, as you would imagine. So that's gone in. The second document is effectively looking at our activity that I talked about before. So as Paul said, where are we against the national trajectories for each of the main pods of activity, which is A&E, non-elective, elective diagnostics, etc. So going back to pre-COVID levels of demand. So we put that in both at an aggregated level for SNE, but also on an individual trust level. We've also submitted 2 documents that the national team wanted around the mental health investment standard. So effectively recommitting to meeting that this financial year, not just at an aggregated level, but also individually each of the main national priorities, so like perinatal, crisis, IAPT, etc. So that's also gone in. And the workforce plan, the people plan, Lisa Llewellyn has also submitted that document, and that might be an area that in the executive that we may wish to have a look at. So I'm conscious we've talked a lot in the past about the other areas, but not so much on workforce. So that might be one we want to have a look through. We've got a session. Well, I've got a session today with the regional lead to go through the assessment of our submission. So at the moment we're on amber green rating, so somewhere between the two, which I think is reasonable given some of the challenges and risks that we've talked about so far in the governing body for our phase 3 planning, and particularly as Ed was saying, any impact of a further COVID-19 spike will clearly impact on our plans that we've put in around recovery. In terms of the main transformation programmes, again, we've covered a lot of ground, so I won't repeat. So on integrated care and elective care, Kate, Paul and I have talked at various stages in the agenda around those elements, be it Dick 111 first, the outpatient work. The only area I would just bring out, which is a positive, is the consultation, my understanding is commenced. Kate might nod one way or the other around the community staffing. So in terms of moving to a 7-day, more broadly 8 to 8, and that is a pan-Suffolk approach. So helpfully ESNEF and West Suffolk, with our support, have coordinated their proposals, because otherwise there clearly would be a challenge if one went with something slightly different to the other. And also, I think with the work we're also doing in North East Essex, we're going to be taking account of that consultation, which is good. In terms of what we call strategic programme, so that's the work that Narinder is working on with other colleagues, just a couple of headlines. So the stroke early spotted discharge procurement has recommenced, and we're still looking to move to a new service model from April, which is good news. You remember that paused during COVID. We'll clearly need to take account of any further COVID spikes, but at the moment we're still ploughing on with that. Lisa mentioned maternity earlier. Just to flag that one of the main areas around that is the potential for reductions in the financial allocation for the transformation work. So the team, with Lisa's lead, is reprofiling, I know, or looking to reprofile that if we do get less money for the programme. And in a similar vein, the cancer programme, we also don't yet know our allocation. So the Cancer Alliance has got the overall, and we're working with them in terms of what that means for Suffolk and North East Essex. So again, with Andy's support for the West, Andy Yeager that is, we'll need to reprofile what we are doing and what we can do on that programme. At the last Cancer Board last week, we have tried to start rebalancing our work, not just on recovery, but on some of the longer term work we were looking at, so the earlier diagnosis of cancer. And Caroline Angus, our Head of Innovation, which is the joint post with Eastern Academic Health Science Network, is starting a piece of work to map out against each cancer type what work have we already got going on in our 3 alliances on earlier diagnosis, and then starting to work through what are some of the high impact innovative work we could be doing to further increase stage 1, stage 2 diagnosis, but also taking a health inequalities bent on that. So actually, where would we best, if we had any funding through the Cancer Alliance, put that money, which may mean a differential levels, just to make the board aware. So we target that money on where we've got the biggest gaps in each of our 3 alliances, which I think is a positive move forward. In terms of the children's programme, just some of the main headlines. I concur with Lisa on the work we're doing now with the new quartet of leaders within NSFT around the children's mental health services. Gary and Leanne within our teams are, are working to the end of September deadline to get the children's mental health pathways confirmed, and then Lisa and I or others will be doing a deep dive on children's with system partners to see where we've got to with that new model of care. On neuro, you'll recall as a governing body we agreed between the two Suffolk CCGs nearly £700,000 of investment earlier in the year in pre and post diagnosis support for children and families with neuro disabilities, etc. We are restarting that work with an innovative procurement coming in October, where, if you recall, we're working with parents and carers who are actually going to lead the procurement with our support, which is a very different approach. We've deliberately paused that in part with schools coming back. We wanted to focus, and a lot of our parents and those who are going to be involved were clearly had other priorities, but we are looking to reboot that in October. And then just concluding with mental health, as Christopher asked earlier around where are we with the process, we had a really good mental health board meeting on Monday night where we went through where the programme's got to against each of the 4 priority groups: LD, crisis, community and children's. We've got a number of deep dives coming up into those 4 areas. Crisis is the first one. You remember that we agreed we'd look to conclude, and Paul and team are now, we've transferred it over to Paul's team now in terms of that assurance process, and we'll be bringing a outcome of that to the November governing body and asking the governing body to make a decision, hopefully on the future commissioning of mental health crisis services. So we're trying to continually balance, I guess is my final point, the longer term transformation work that we're looking to keep moving on with the day-to-day recovery, and they're not completely separate, but clearly at the moment there's a tension to some extent between keeping moving on those longer term ambitions that we've got and the immediate stabilisation of services and trying to continually plan and deliver against COVID and winter. And like Lisa, happy to take questions.
And you have the first one from Kate, please.
Mine was an addition rather than question. So if there's a question on what Richard's just said, maybe take that first, Christopher, sorry.
Godfrey, have you got a question on Richard's presentation?
Well, it was only really a comment or a plea even to say that in terms of early cancer diagnosis, that's one of the priorities on the list for PCNs to be undertaking this year. So any project that's being done to look at how that might be tackled should link in with the PCNs across the patch.
Yeah, absolutely. Andy might come in, but Caroline's aware of that, and we're creating a small task and finish group across Suffolk and North East Essex, as I say, to do that piece of analysis work on what's the JSNA telling us, what are we already doing, and then what could we do?
Yeah. Thank you.
Andy, have you got a question? You're on mute, Andy.
Thank you. We are linking in with PCNs, Godfrey, and I was at the meeting on Monday with Caroline about this, and we will involve PCNs because we realise actually PCNs have a huge role to play with regards to early diagnosis and are a beacon of hope for us at the moment. Thank you.
Thanks, Andy.
Thank you. Kate.
Andy, I loved that as a phrase. They are a beacon of hope for us. I might write that down somewhere publicly. Godfrey made part of my point, so around the fact that actually we need to be tying the primary care, the very clear structure we've got around primary care networks, development plans as part of the contract into the transformation piece, because much of the work that Richard's team are doing and we're doing more broadly supports that. To let Andrew in. The other point that I wanted to make adds to some of what Richard said in terms of the work that we're doing with community services. At the moment, the hospital have done a piece of work called What Matters. What Matters to You. I keep getting that confused with what are we missing. What Matters to You, which is a huge consultation exercise, and that's given us a wealth of information from our community services staff around how they've felt during COVID and how they feel themselves in their roles, etc., etc. It's a really rich bit of engagement, and what we're doing is taking that and working with Sandy Robinson and Leslie Standing from the hospital to do a further bit of engagement about what needs to happen to empower those staff to be able to work differently in a more integrated way. And I think that we're 4 years into the community services contract, and the language in the contract was about the hospital hosting these services. And I think that's part of what we are unpicking now, to sort of make sure that our community services have an identity that's linked to primary care, social care, their local community, so that they have enough identity and empowerment to be able to feel that they can do their role and more, because they are such a key part of almost all of this, demand management, cancer diagnosis, resilience, etc. And I think from a primary care point of view, we need them to be as strong and as empowered as possible. So that's a brilliant piece of work, and I suggest that we bring something back to the board. I'm happy to facilitate that, a paper just to give a update on where that's got to and what the nuts and bolts of that need to be. And I did have a second point, but it has unfortunately left my head. So
okay.
we might pop back in.
Thank you. Any further? Okay, thank you. Richard did say, Kate, you might want to contribute in your own right to the integrated performance report discussion.
Which is very generous of him. I can contribute in my own right. I'm going to take the slide as read, because it doesn't change hugely. I think the points to note are our residual ones, and Paul pulled out the point around LD, SMI and dementia, and that is our residual challenge. And I do think maybe to crystallise some of that, we perhaps again need to bring something more formal back through execs and this forum, just to make sure that we are, because I know there's a significant amount of work going on in each of those areas, so making sure you've got visibility of that and you're happy with that, I think probably would be a positive move. But nothing further, happy to take questions.
Thank you. Any questions? Okay, thank you very much. Just for the administration, I stumble on this item every time. So could I ask particularly Joe to liaise with Richard and to list the directors on the agenda in the order in which they would like to speak for future board meetings, please. I've probably had about 7 years of getting that wrong every board meeting, and I would like to get it right in consultation with you all before I retire. Thank you. Right. Could we move on, please, then, to the governing body assurance framework? Amanda.
Thank you very much. Thank you, Chair. So here we have the September GBAF. A lot of it we have seen before at the recent clinical scrutiny, but we have actually updated in the last couple of weeks. A lot of the risks thus far have been shared, as we've heard through the IPR in the previous paper, but the risks that we haven't covered, there's a couple that I just wanted to highlight. The first is around cybersecurity, and we know that that's been on our GBAF for several months for the right reasons, and we all know that work continues with the IT team and NEL, our IT provider, on mitigating the risks. We presented a deep dive on all things cybersecurity at the Audit Committee last week, and we are periodically invited to update that committee on how we continually manage that risk accordingly. In terms of the workforce risk, as we briefly heard earlier on, a lot of that work is being progressed through Lisa Llewellyn and her team, and also through the training hub and the ongoing work that's just commenced around the people plan. With regards to Brexit, the EU withdrawal, we know that earlier on this year it was a key feature of the GBAF. It then subsequently moved to the Corporate Services Directorate Risk Register. From October, that will reappear on the GBAF, so at our next governing body, we will see that as work is starting to now escalate on all things related to our withdrawal at the end of December. And last week we had to confirm back to region who our SRO would be for Brexit going forward. Health inequalities is a new risk that's bubbling away, and as Lisa mentioned yesterday at the Ipswich and East governing body, and given all the work that's happening at the moment, it's very likely that health inequality agenda and the risk associated will be discussed at the next risk forum, and very likely that it will appear on the Quality Directorate Risk Register. So they, Chair, were the key updates that I wanted to bring out from the GBAF, but very happy to take any questions. Thank you.
Ed?
Thank you. I don't think this is a major risk, but it is a significant risk. So people may be aware from the papers, there's been some debate in Stanton about the extension to the surgery, and the council there haven't made their mind about whether they want to support the planning permission. So it's just, if that wasn't supported, we would have then 6,000 patients that would need to find a new practice in that locality. So I think it's just a risk for us to be aware of. I don't know whether Kate or Andrew want to add to that.
I'm happy to. Yes, I think it might.
Please do.
I think it would be worth working it up. So, Amanda, if we take that as an action to work that up and work through the mitigating issues, if that is the direction of travel as it plays out.
Yeah, no problem.
Godfrey?
Just a different question briefly for Amanda. Who is our SRO with responsibility for Brexit going forward?
So as previously it was me, and Ed has confirmed that going forward it will be me and then Pam Green for North East Essex.
Thank you.
Andrew? Andrew, you're on mute.
No,
Andrew Hassan.
I've got it.
Wishing to speak.
Not on the subject of Stanton, but on the subject of Brexit. It has been on the APC's agenda as a standing item for the last 2 meetings because of the risk to medicine supplies, and the fact that it took about 18 months to build up medicine supplies in preparations for the last no deal, and we've only got 4 months left to build up those supplies.
Thank you, Andrew. Noted, and that will be fed into the forums that are starting to resurrect. Thank you for that.
Thank you.
Thank you very much. Right, I think you've earned a break. I should like to reconvene at 10:55 exactly, which does give you time to get a kettle on and use it. Could you please all, as previously requested, turn off both your microphones and your cameras, and I look forward to seeing you in what's now 13 minutes. Thank you. It is 10:55. Welcome back, everybody. We now have, although part of the finance performance scrutiny, we now have actually 3 consecutive finance papers, one of them being part of governance and corporate business. So we're on item 12. Jane, if you'll be so kind, please.
Yes, thank you, Chair. And apologies that there are a number of financial governance papers today. I will try to cover them adequately, but I won't be dwelling on lots of the detail. Having said that, I think it is worth spending a little bit of time on paper 12, which is about the financial regime for the second half of the financial year. So as you heard earlier, we were up until the end of September, and we've been in a kind of spend what is required for the NHS to deal with COVID for across, and that's the message of being across the whole of the NHS, with a system in place to reimburse us for any costs over and above our allocation. When I wrote the paper, which is not that long ago, we hadn't yet heard what was going to happen from the 1st of October, and hence the paper is written asking for assuming that would be extended, that period. However, subsequently, in fact, it was just before we had the Finance Committee on Wednesday, we did hear that the announcement about the financial regime from month 7 has now come out. So I gave some basic information on that we received to the Finance Committee, but actually it is in line with what we were expecting. So if you look at the paper and in section 2, the September update, the way that things work is pretty much in line with the set of bullet points included in there. So it's a kind of a hybrid situation, I would say. So we've not gone back to our usual arrangements whereby the CCG receives its allocation on a weighted capitation basis for its population, and then makes its own decisions about where to spend that money in line with, you know, existing commitments, etc. It's a kind of a hybrid insofar as that we have been given an allocation, and as Ed mentioned earlier, that allocation is given on a system basis. So Suffolk and North East Essex, although transactionally it will still work via the individual organisations, and particularly West Suffolk CCG in this instance, we have been given that allocation. However, there are bits of the jigsaw which are still fixed. So we will continue to have the block contracts which have been centrally calculated for our main providers, in this case for Norfolk and Suffolk Foundation Trust and West Suffolk Foundation Trust, particularly for the West. They have been receiving top-up monies to help the trust to be able to cover COVID costs and to break even. They will now be routed via the CCGs, although they will be changing slightly. There are expectations that income, third-party income received by trust will start again in the second half of the year. We've got some work to do on that, because things like car parking, for example, we know will not return to previous rates very quickly at all, given lower levels of activity. Anyway, I won't go into the major issues on that. The second bullet point is that so far us as a CCG and our provider trusts have been able to make claims, and us as a CCG we've been able to make claims on behalf of primary care, etc., for additional COVID costs. That will no longer happen from the 1st of October. And what has happened is that in the allocation that we received last week, we've received an amount of money for the system that's around about 48 million, so it's not insignificant by any means, to cover the costs of COVID from October to the end of the year. Now, if you compare that with the costs that we've experienced in the system, and remember, this is the whole of Suffolk and North East Essex I'm talking about, not just West Suffolk, we're anticipating that there'll be more like 90 million in the first half of the year. We haven't got the September figures yet, hence I'm estimating it. So it is quite a significant reduction. But what's happened at national level is they've looked at the different categories of spend within there, some of which will continue to be managed centrally, such as the hospital discharge programme, some of which there's anticipation won't continue, such as extra costs associated with bank holidays and procurement of personal protective equipment, which is now being done centrally, and so therefore the overall allocations have been adjusted. and they've been distributed on a fair shares basis across the country. So, so we are working through how we will be looking to distribute those. The particular issue for us in Suffolk and North East Essex is we are the host for the regional ambulance service, and at the moment we haven't got any details exactly how they have been treated in terms of the allocation, because we know that their COVID costs in particular have been extremely high, and we need to make sure that we treat the ambulance trust fairly, but also that we are not disadvantaged as a system by being a regional host. So there's quite a lot of work to do around that. As I said earlier, the financial architecture is similar to what we're expecting, so those block payments will continue. We are still awaiting information on a lot of the long-term plan funding. So things like the mental health investment standard, maternity funding, etc., not necessarily included, or it's not clear how these are included in the envelopes, and we are expecting additional announcements on those. The final bullet point in the paper on this section is about that marginal cost, which we touched on earlier, I think for Godfrey's question. The detail has to be worked through on this, but as far as I understand it, we've submitted our plans, our activity plans, as Richard spoke about earlier, and our performance plans in line with the phase 3 recovery, and the expectation being that we get to set levels of last year's activity, 90% rising to 100%. And the payment system is trying to incentivise that to happen, and trying to incentivise the NHS to get back to previous or indeed increased activity levels on elective and outpatients. And so there will be a marginal cost payment. So if you remember, within our system, we used to work on a system, payment by results, where activity was paid for depending on volumes using a national price list. We don't think it will be a complete return to that. It will be a marginal payment for additional activity. So, for example, if a trust goes over what's expected, then it will receive extra funding, and we believe that's either 20% or 25% of cost. It's not a full cost additional like it used to be under payment by results. It's a marginal. It's an extra bit to reflect the extra costs of doing that. And conversely, if activity levels are below, and I assume that there will be a tolerance level in this, we need to work through all of the detail on it. But if trusts are below the trajectory that they've agreed to, there will be reductions again at that marginal rate of 20 to 25%. So we do need to work through the detail on that, whether or not that will be operating at system level or at individual trust level. But as part of the planning work that I'll speak more about in a moment, the trusts have been estimating what their risk might be around that. West Suffolk has estimated that their level of risk might be about £1 million on that, although they did say that that's quite a high level estimate, and they need to work through individual specialty level, looking at the achievability of the individual targets for each specialty. So as you can imagine, all of this is moving quite quickly at the moment, and so I had a look at the recommendations which I'd written in this paper, and actually most of them still stand. The first one doesn't, because we know now that the emergency finance period is not extended in the way that we anticipated, although on a national call with the National Finance Director last week, he did say that if the second wave hits in a way which necessitates it, then we may return to that later. Assuming that's not the case, we are into a more normal situation around allocations, as I've described. So it will take us some time to work through those. As I said at the Finance Committee, and I said earlier in this paper, we are working through. They are quite complicated, and there's an awful lot of detail that we don't yet have, and we need to work through. Just to demonstrate that, on the national webinar, there are over 250 questions raised of the national finance team, and we haven't received the answers to that. Not from myself. I did put a couple of questions in, but that was from the NHS finance community. It's very complicated, and obviously everyone has lots of questions, just like we do, around ambulance trust and how the allocations will work. So hence me basically asking if that second bullet point can still be in place. We haven't yet been able to work through the detail for the CCGs and for our provider organisations, and it's doubtful that we will have got all of that in place and been able to agree it through governance committees by the 1st of October. Hence, I am asking for a roll forward of the arrangements that we've got in place at the moment, and that we continue with that work on the financial plan for the second part of the year. And as we won't have a governing body for 2 months, that we continue to work through that and go through the detail with the Finance Performance Committee. It may mean that we need an additional Financial Performance Committee meeting, apologies for members of that committee, but so that can be looked at in detail, ready for final sign-off by the governing body in November. So apologies that is a bit of a canter through, but effectively things are moving quite quickly here. Just wanted to really give the governing body assurance that we are working hard to try to get ourselves into a position where we're clear about both the CCG and the system allocations from the 1st of October, but it will take a little bit of time for us to work through that.
Thank you. Does anybody have any questions? Yes, Jeff. No, Ed. Sorry. Yes. Yeah, Jeff first then. Sorry.
Okay, don't mind. Thanks for that update, Jane. Very pleased with that. I'm not going to ask any detail. I accept it's very challenging, so I look forward to it coming back to the Finance Committee. I'm happy with deleting the first bullet recommendation, but I suppose ultimately, depending on how things go with COVID, this is like putting a cash limit on COVID going forward, isn't it?
No, you're absolutely right. It's basically giving a cash limit to the system, and should the COVID costs re-escalate to levels that we've experienced in the first part of the year, there's not all systems will experience a real problem. So as I said, the National Finance Director did say that there's a kind of a break glass clause should that happen, because obviously the expectation is that the NHS will provide the services that are required.
Thank you. Ed.
Thanks, Jane, for the update. I had a cupcake during the break, so I'm high on sugar, just to warn you. So my question is, what's your perspective, and maybe other finance directors and CCG's perspective on the move to system allocations is a big step away from clinical commissioning groups as they were set up. So how does this make CCGs relevant, if you like, going forward, if we're going to be operating in this way, or does can both ways be accommodated? What's your sense?
Golly, I might definitely need some of those cupcakes, Ed, to deal with those questions. So it's quite interesting actually how the allocation has come out. So it's a bit of a hybrid actually. So it's got in there detail about individual trusts, it's got detail about individual CCGs, but some elements are at system level, and then they've all been kind of combined together. So the main element that's at system level is the COVID pot, if you like, and that's what we're trying to just get some detail about how that's been calculated, particularly in the light of having the ambulance trust within our patch. So it's not moved there 100% already, but I think, as you say, this does signal the way forward. The architecture in terms of actually, sorry, I'm going to sound very finance and boring here, but that making the transactions and making the payments can only work at CCG level at the moment. There is the system doesn't exist in terms of bank accounts, etc. So all of that has to work through the individual CCGs. But I think it does very strongly signal that there is going to be a different way of doing this. So I think in the past it's been very much more about sort of national and region determining the allocations and the shares for individual organisations, whereas this kind of pushes that down a level. I say it's just a taster because it's not the whole lot, it's just part of the allocation, but it is probably one of the first significant steps alongside some work earlier in the year on capital that moves us forward. So at the moment, CCGs are absolutely needed to deal with the transactions, but in terms of decision making, we are now seeing a bit of a shift, and I think it's important that as three CCGs we do continue to work together and look at those together, because I don't think one CCG is going to be able to make decisions in isolation.
I just think it's important we talk about it, because what I don't want us to do is to drift into a parallel system being created and therefore confusion. So I just think it's an important one to talk about.
Thank you. Can I have one? I didn't fully understand the PBR top-up point, because I thought that not being on PBR was voluntary from the point of view of the hospitals, and therefore presumably they still have the choice, if it were financially advantageous to them, to say, well, yeah, nice bit of top-up, it's 25%, we'll go back to PBR, thank you.
So if we were in an ordinary year, you'd be absolutely right, Christopher, and that there is the sort of the choice, although the national direction of travel is away from payment by results and onto blended contracts. But you're right that there are some areas of the country that up until COVID hit were still operating on payment by results, and that is something that our trust could have opted to do. Under the current arrangements, the payments for trust are made by mandatory block contracts, so there is no option to move to payment by results at the moment for this year.
So PBR has been suspended nationally, has it?
Yes.
Thank you. Yep. I hadn't understood that. Thank you. Kate.
Just to build on Ed's point, because I think it's something that we do need to give some airtime to, and I think it's almost broader than finance. It's finance, but I do think we are also operating three separate systems still. And actually, when you're looking at the integration piece, and Richard used the example for community services and 7-day working, we've got a paper coming on the prescribing committee, the area prescribing committee coming as well. I think we are a mature enough system to understand which bits make sense at scale. And I think what we need is the machinery to help facilitate us being nimble in that space, but also us being able to give assurance to our locality footprints, West, East and North East Essex, that isn't a loss of identity or autonomy. It's all part of a bigger conversation, and I think we do need to keep having it, and that links into the Alliance Committee, the System Exec Group committee conversation around actually what the autonomy at a locality level is. So I think that it's something that I very much support, having the conversation as transparently as possible. And I think COVID in some ways has given us as with everything, a kind of a rocket in terms of pushing this agenda to the forefront, because we had to, because it's a necessity of the situation at the time. So just a comment, really.
Thank you. Any further on that paper? Okay, well, you've almost done paper 13 as well, haven't you, Jane?
I have. If I may, we could almost take the two together, but sort of as almost a corollary to that, when I was expecting the emergency arrangements to be rolled forward, I basically updated the paper that we took last time about rolling forward both the extension of the emergency limits and the COVID Resource Approval Committee, the CRAC committee, for a further 2 months. Following discussion at the Finance Committee last week, despite the fact that the financial arrangements are changed for the second half of the year, there are still some good reasons to keep these in place, not least of which is the possibility of the second wave, but the second being that although most of what will happen in the second half of the year will return to local management, there are elements such as the hospital discharge programme that continue to be on a claims basis, and therefore having the approvals committee in place is really helpful in terms of managing that and managing that quickly across the 3 CCGs and working with the county councils. So as it says in the paper, and certainly even more so now, we have more clarity on the second part of the year. I don't anticipate that the committee will continue in the same way as it has, but I would like to ask to keep that committee going. We will use it only when necessary, but it will save us needing to come back to the committee should we need to stand it up at short notice.
Thank you. Everybody happy with that?
Yeah, I am.
Thank you. Thank you.
Agreed.
Okay, right. On to the next section then of governance and corporate business. Still with you, Jane, the Financial Performance Committee annual report.
Yes, thank you, Chair. And obviously there are lots of members of the Financial Performance Committee on the governing body. So hopefully you'll recall that at our meeting last week, we took this summary to the Financial Performance Committee, which really sets out what the committee had been doing for the financial year that ended on the 31st of March 2020, takes you through how the committee has achieved its terms of reference, and it provides a little bit more detail about how the committee has changed over the course of last year. When we were looking at this a year ago, the Finance Committee was meeting on a monthly basis. We have altered that in line with movements towards the Alliance governance, so to reduce the frequency of the CCG committee and to introduce the I'll try and get the term right, the West Suffolk Resource Group, which is part of the Alliance structure. So other than that, Chair, I'll just commend it to the governing body to approve.
Thank you. Everybody happy? Any questions? Thank you very much.
No, happy with that, thank you.
Thank you. Item 15, the Area Prescribing Committee. Is that Kate or Andrew?
Andrew's camera's just pinged on. It's Andrew.
Andrew, okay, thanks.
I'm happy to support.
This is the first report we've put forward of the Suffolk and North East Essex Joint Area Prescribing Committee and on our activity since we were given some delegated authority. And so I think the report speaks for itself. I'm happy to take any questions, but I think it has been a successful example of cooperation across the system.
Does anybody have any questions for Andrew? Jeff?
Thank you. It's not a question. I just welcome the report. I thought it was very helpful and informative. Certainly raised my knowledge. So thank you very much.
Delighted to help.
Just to add as well, I think it also was a really valuable tool over the last 6 months, and it will be a very valuable tool going in and through winter in terms of just being able to bring all that clinical knowledge and leadership together into one conversation.
I think my final comment is that there is a rotating chairmanship of this committee. So David Egan was chairman for 2 meetings, I was chair for 2 meetings, and a GP from North East Essex has been chair of the last meeting and the one that's coming up, and it then will rotate back through the 3 CCGs, which I think is a very effective way of ensuring that we share the burden as well as the success.
Thank you. Does seem good. Linda?
Thank you. I have to ask, because in the paper it says patient and public engagement, please review terms of reference. I can't see the terms of reference in this paper unless I might have missed something, but I just wondered what that meant.
I think the difficulty is actually determining who will provide that public and patient involvement. There is public and patient involvement in each CCG, but at this level of having a joint committee, the issues discussed are often reasonably complex, and I think that the patient and public involvement would probably be better used at a local CCG level rather than at the area prescribing committee. But I think it's something that we haven't determined yet, and we will be returning to that and considering how we implement that in the future.
I'm happy to help and the CEG to be engaged, but I'm also assuming that perhaps different pathways, rheumatology, end of life, that sort of thing, that there might be patient engagement in those pathways that might influence decisions as well. But it just might be helpful to perhaps have a strategy or to have it recorded in some shape or form. Thank you,
Linda.
Would it be helpful if Linda were invited to 1 or 2 meetings so that she gets a feel of the business transacted and therefore might be able to help in formulating the patient and public involvement policy, since she's raised the issue?
Happy to bring Linda into that conversation. Absolutely, it's almost there as a marker, because it's the aspiration that is. I mean, there's even been conversations around potentially having a lay chair. I think we've touched on that before as well. We're talking about the rotating chair, but as this evolves, I think that is part of where we want to get to. And I think one of the big pieces around, if we've got strength in the conversation being across the ICS footprint, that also helps with some of our communication messaging around medicines, and I think that has to be sort of co-produced and engaged within the right way. So it's a really positive prompt, Linda. Thank you very much. We can take it back into the meds management team.
Thank you.
Okay, thank you. Right, the audit committee, Jeff.
Thank you. So this report, I think, ably demonstrates the full programme of work that we've carried out during the year and satisfies our terms of reference. It's been a very pleasing year. We've had a full coverage from our new internal auditors, RSM, and we've got 6 out of 8 substantial assurance reports. Our external audit report, as you can see in the paper, has been pretty exemplary, a clean bill of health on the accounts and an unqualified value for money opinion. And also we've received regular reports on fraud updates, although we've had little fraud, I'm pleased to say, in the CCG, but we're on top of all those policies and procedures. In addition, we've had reports on couple of reports on cyber security, which we've been able to comment on, which have been very helpful to assure us that work on that important aspect of our processes is working well. We've had reports on the general data protection regulations, again, another important aspect of our work. Together with assurances, we've been able to give assurances around the GBAF, and we've also done a self-assessment. So I think all in all, we've satisfied our terms of reference. It's been a good, productive year for the audit committee, and I will place on record my thanks to the officers and members of the committee supporting me as chairing that meeting. So thank you very much.
Thank you.
Happy to take any questions.
Questions for Jeff? Okay, thank you very much. Item 17 then, the formation of the auditor panel.
Christopher, sorry, I think the governing body need to approve the audit committee terms of reference.
Beg your pardon, okay.
Yeah, shall I introduce this one? But obviously Jeff may well want to contribute. We are the terms of reference obviously are subject to regular review for all of our key committees. What we're taking the opportunity to do is when any terms of reference come up with across the 3 CCGs, we're looking to align them where possible. So the audit committee terms of reference came up for renewal, and we have undertaken an exercise to align across West Suffolk, Ipswich and East and North East Essex CCGs, and also to take into account the latest advice from the HFMA Audit Committee Handbook. And hopefully we've now got a good, effective terms of reference building on the ones we've used in the past, and that will lead us going forward. We did look through this in detail at the Audit Committee last week, and they were recommended for presentation to the governing body.
Thank you.
I'm happy to support those terms of reference. Thank you.
So this is item 16B, just so everybody is clear. Are we all happy to support that?
Happy to support, yes.
Thank you.
Thank you.
Item 17 then, Jane.
Yes, thank you. Sorry, we're nearly there on all the audit and governance items. So again, working across the 3 CCGs, we are trying to align as much as possible to try to get best value out of our joint management team and reduce the sort of burden on time for our governing body and committee members as well. So as Jeff said earlier, we've already got a single internal audit provider in place across the 3 CCGs, and we are now going out to tender for external audit provider because the Suffolk contracts had come to an end, and we're taking the opportunity to align across the 3 CCGs. So as part of that, it's a formal bit of process that we have to do. We have to put in place an auditor panel as a committee of the governing body, and this paper basically just uses a standard terms of reference that we've adopted from the Audit Committee Handbook, and it just it sets out our proposal around that Audit Committee panel. So we have we put in the paper who we're effectively proposing that the members of the Audit Committee form that panel, joined by myself. I'm not a formal member of the Audit Committee, but obviously I'm a member of the governing body, so can be part of that panel. you will note that Steve Chicken, who is currently absent, is on there, but we have taken into account that there are enough members for us to be able to form the committee properly and to be able to make an effective decision in conjunction with that of Ipswich and East and North East Essex audit committees as well. So hopefully reasonably self-explanatory, but basically we just need a very short action committee that will look at the responses around the external audit tenders and make help the governing body to just get through that bit of process.
Thank you. Any questions for Jane?
No.
Do we
agree that?
Do we approve the report?
Yes.
We do. Thank you very much.
Thank you.
Okay, then on to the minutes of meetings. Jeff, you usually lead us on this one.
Thank you, Chair. There's several committee minutes, several minutes of committees attached: the clinical scrutiny, primary care commissioning, COVID, several items for the COVID committee that's met several times over the last couple of months, and the commissioning governance committee. I haven't got any specifics on any of those, unless any of the chairs have got anything to draw out in particular to the governing body. I think the CRAP committee is fairly detailed in terms of the approvals that's been given, and likewise the commissioning governance is fairly self-explanatory. So otherwise, I'd ask the governing body to note and accept those minutes. Thank you.
Thank you. Everybody happy to accept all minutes? Any questions? Okay, thank you very much. So the next meeting will be on the 25th of November. I can't think that it will be in any format other than this one. So we now move on to questions from the public, and I have been given notice of 3 questions, which we will take one at a time, and which Simon has kindly agreed to read. They are all from the same author, but they are on different topics, and I think warrant treat. We've got the time, so we'll treat them individually.
Thank you very much indeed, Christopher. We have, as you mentioned, there 3 questions from Councillor Margaret Marks. The first question relates to Think 111 First, and the question is as follows: is there an additional, more detailed paper identifying exactly how this system will work, and will this holistic approach be operating with patients who go via the normal primary care system? I note this is planned to start on the 1st of December, but with the expected COVID increase, is this realistic?
So I'll take that.
Yeah, Richard, thank you.
So
Yeah.
as I said in my comments earlier in the agenda, there will be a business case coming through to the clinical executive in October. Happy, Councillor Marks, that our lead has a conversation with you if that would be helpful, and through the CEP, Linda, if that's helpful as well. Yeah. In terms of will it go on, I think the comment I was asked earlier by Godfrey on finance is probably the same answer. I honestly don't know. I think at the moment they're seeing this as something that will help winter planning, will help manage demand. So probably my personal view on this one is that it will still move forward, but they are looking at the early learnings from the 3 to 4 pilot sites. So I think we need to keep it under review, but keep planning as if we need to have it going forward in early December. But yeah, happy to have link our person to Councillor Marks to have a more detailed conversation.
Thanks, Richard. The second question, the national agreement with private providers ended the end of August. Is there a new national agreement to support catching up with the vast numbers of patients waiting interventions?
So I'll take that one. So the contract with the independent sector providers, which as Councillor Marks describes was a national contract, is due to end in its current formation imminently. There is then meant to be a national procurement that I haven't heard the latest on, but happy to find out more, which will take us through to the end of March. So the expectation locally in terms of our recovery plans, so against the work that Paul described earlier around getting back to pre-COVID levels of activity, has been put in without any independent sector capacity. That was what we were asked to do. So ongoing independent sector capacity will effectively help us to get to where Paul described as the 100-120% that we need to get through some of the backlog. So it's a watch this space, I'm afraid, at this moment. We haven't had the final clarity on the national procurement.
Okay, thanks, Richard. And the third and final question, please may I have information on the numbers of patients who have significant delay in treatment? Councillor Mark says that she has a number of residents waiting orthopaedic interventions who are now suffering with associated problems, which will further impact on the NHS, and there is currently no visibility when their initial surgery will take place. Are patients being risk rated?
Might be one for Paul, mightn't it?
Yeah, so again, in my earlier piece, I described the issue around RTT, and I described the ongoing discussion around the risk stratification of patients and actually creating that visibility about the patient, how they're safety netted essentially in terms of their ongoing management. So that piece of work is very much ongoing. We are waiting, I believe, some national guidance on that, but clearly as a system, we are currently looking to see how we can best achieve that. So absolutely, when that information is available and capturable, we can absolutely share it.
So that includes the numbers in there, will it? Yes, for Councillor Marks. Okay. Who's going to liaise with her on that? Because
I'm happy to pick that up.
I think yes. It sounds like she would appreciate discussion outside the meeting, having marked the point inside the meeting. Okay, that brings us to the end of. Got Richard? You want to say something?
I think Lisa was looking to.
Lisa.
Sorry, I was just going to say I'm happy to be part of that conversation if it's helpful, just to clarify with the councillor around the harm review process that we have in place and the risk stratification around clinical prioritisation, if that's helpful.
Thank you. Okay, that ends the public part of the meeting. Thank you very much, everybody. I think we've got a separate sign in for part 2, haven't we?
Yeah, I think you need to log out and
yes. I certainly don't think we should wait till 12:30. Shall we start at 11:40? Yeah. Just give you time to swap over and do anything else that's essential.
Thank you.
See you soon.